that, we should make a position that a women autonomy and a women right to make a decision should be central to all the policies that we are leading. And when we say women and girls, it's not about who they are, where they are, because we know that in the data we need to be specific. We need inclusion in a true sense, not for the surveillance and not for the data, but for the very right that they deserve. So if they are not documented, if they're invisible population that we call, this is a very long struggle that I've had with the population ministry when it used to be a ministry. I remember after ICPD, I wrote a long 2-page email to the DG at that time. I said, you have signed ICPD, you have gone to the Cairo, the Prime Minister is committed, you're still asking women to bring her husband consent for tubal ligation. You're asking her to bring an NIC for a long-term method. Why should she do that? While a man who goes to vasectomy does not need a woman permission, does not need anything. And the providers are denying services, and the woman, her husband is an addict or somebody who is a narcissist who doesn't want to give her the permission, and she's denied the services. And I said, please, you have to honor what you have committed. Let it be a women's right. And I know we have been saying women-centric, please put women in the center, but sometimes I also feel that when we say put women in the center, it's like 12 men are sitting and we are looking at women. Women bodies are treated as commodities. It's target-driven. And we have not even had that kind of give the leadership in women's hand, and that's what it should be. And it doesn't mean the women who are sitting at the top position, women who's walking into your facility. She should be the one who should know, who should have the right set of information, and she can take that. And we should not be worried about whether she doesn't have an NIC, she doesn't have a permission. Just give her the service she needs. And that's her right, her basic human right, and that should be non-negotiable. I'm a part of the Women in Health Global Network. I'm a part of Women in Health at Pakistan level. And what we have seen from what we have collected the work, that 75% are women in the health ministry at different levels, usually at the mid and lower level, the large percentage. But usually when you go to the highest, and now it is changing, I've seen a lot in federal, we have a DG sitting here in Punjab, we are seeing women secretaries, but you go to a health ministry and you see all men sitting there, and sometimes you get the pictures of a very important post-abortion care and postpartum family planning, and there are 30 men sitting with no women in the room. So what I'm trying to say is that unless you don't make women part of the conversation and you don't let them take their affairs in their hand, and that woman who's walking into the clinic, we should never underestimate a woman's intelligence, and anybody's intelligence, not women, a human. They would know best to do if they are provided with that. So we are calling of respectful care, we are calling of empathy, we are calling of compassion. The provider bias is very real, and the provider bias is extremely real. We need policies that have that kind of surveillance, that where are the biases happening, and why a woman is refused a service when she walks into the clinic. And then the continuum of care, which is very important, from adolescent to pregnancy to postpartum. We know that at every touch point in her life, she would need that kind of information, which we fail to provide in a classical facility setting. Although we keep pushing women to go to a facility, and she should be in a facility, but then the continuum of care is not provided in the way that it should be. We have been calling out for the shifting the task, make the mid-level providers, the kind of providers we have seen Sweden, going almost to zero their maternal mortality rate, mainly through the midwives. And we know that the lady health visitors and even the lady health workers, we are seeing Ethiopia and many African countries doing wonders with the mid-level provider, with the task shifting. We do have policies in one or two provinces, but they are not implemented in pure spirit. So what I'm saying is that we have to start doing that. And the most important point I want to say is that we need community-led accountability system. We just hired, of course, now I am also hired as a consultant for do this work, but I totally believe in, the community-led accountability project that I also got from Gates Foundation to come to Pakistan, that, let community hold the systems accountable. Because for them, everything is like, of course, it's happening. It's the will of the God sometimes. It's the apathy. जी गवर्नमेंट के इदारों में तो ऐसे ही होता है. They accept it as a fate. और जी प्राइवेट सेक्टर तो ऐसे ही करता है. No, hold the systems accountable, and they're the best agents to do that. And in that way, and we have seen the women groups that we have got collected in the community from a very, union council level to all, they would understand immediately what kind of rights they have as far as health is concerned, what kind of rights they should be asking for when they walk into the facility, what are the red signals that they should note, and what are kind of things that they can report back. So I think this is, then of course, they need that kind of a agency and empowerment and a support in the system. I was telling, some of the people in the ministry that one of such projects in India was accepted by the government of India, and they have asked them to do it for them, because they say our field is not able to detect what you could do. So you need that kind of a trust to build that, and you don't take it as a threat, that if a community is organized and is telling the health system, we are talking to PPH and saying they are very open, I must say that you need to rely on these mechanisms instead of, and in that, the undocumented, the invisible, the women who get sidelined, who get, sidetracked by the mainstream, within the mainstream population, would come out visibly. And I'll say the same thing for the young people, that the young people are the most vulnerable in the sense that if they want any sexual reproductive health services, and first thing they'll ask, are you married? Because, in a facility, this is a question that is asked, and they are denied services of any kind if it is related to SRH. And I think in that sense, there is a lot of provider bias, the system bias, which push them back, and we need to start looking at this, because the majority of this country are young people, and how can we deny them these rights? So I think there's a lot of things that needs to be done. It's like a drumbeat. We keep on saying that at all the forums. We are very happy to sit with the government. We have done that for various policies, various roadmaps, still working on some of very important, factors. The postpartum family planning, Madhya is here, Dr. Shabana is here for the PPFP and post-abortion family planning. We keep putting abortion under the carpet, although 3.8 million women undergoes abortion in Pakistan every year. But we don't talk about it because, no, it's a word and it should not be said. It's a health issue. It's an issue that a woman faces, and she needs quality health care. Full stop, period. Should not go into morality and judgment and all of that. And these are all married women. The Population Council and Good Market Study have proven that. So it's because of the unmet need. It's because the system is failing them. But we cannot leave them alone. So I think, how do we bring all of this together, that we are not just working on the surface, on a very clean kind of a population? Okay, you walk in and you have a straight record and we will serve you. No. I think, I'm a medical doctor and we take oath that we do that, but we don't see that happening in the real. And that is where we need to really start pulling all the lens together, and where we can really move the needle, which we have not been able to move because we have been very selective in our approaches. We have been, this is an approach that we will take. We have not tried to, out-of-box thinking. How do we include, NGO and private sector, of course, have very flexibility, and they have shown the result in a much rapid way. They go to a community in 3 or 4 years. They take the CPR to the highest level because they are able to do all of this, which may be difficult in the larger public sector, but it's not something that cannot be done. And we would like to recommend that it has to be taken. The best practices have to be taken to scale.